Very good afternoon. I am Dr. Bijoy Dutta, Associate Professor of Cardiology and IPDI. I'm here to present the complication toolkits for PCI. Major complications of PCI are rare, but can be catastrophic if not successfully managed. In contrast to the early days of balloon angioplasty, the complications were more common. Now it is less common, even in once a year or once a career for most of the interventional cardiologists. However, we should try to have an effort to avoid, recognize and manage complications which has significant impact on patient survival and healthcare cost. So operators should be prepared for complications and their management, especially if they want to do complex and high-risk procedures. Unfortunately, few opportunities exist for training in complication management. Learning by doing is unlikely to be sufficient to develop competency in complication management. That is the main problem. Most of the complications are already discussed: the coronary perforations, major dissection, hemodynamic collapse, no flow, slow flow, or entrapped equipment, which are very rare. So general management, in general business complication management, all the cath labs should have a standard protocol and sets of equipments and resources to prepare for PCI complications. These are called the complication kits or cart. And every staff of the cath lab should have to know the exact location of these kits and to use these kits when required. And every cath labs and should have a transfer protocol who do not have a cardiac surgery backup. And this is the recommended resources. First, in the cart, in the room, and in the hospital. 3. In the cart, we should have a pericardiocentesis tray, covered stent, coils and microcatheters for coil delivery, snares, thrombin and microspheres. In the room of this cath lab, we should have a mechanical circulatory support device, ACLS drugs and defibrillators, contact information of the individual who can help you in a emergency support or advice. In the hospital, we should have a cardiothoracic surgery backup or perfusion team backup. We should have a peripheral vascular specialist, echocardiography, and experienced cardiac ICU support. So in general principles, if the complications are minors like non-flow limiting dissections or the perforation of the small septal arteries, it may not require specific interventions if there is no hemodynamic instability. But sometimes aggressive management of a complication may be riskier than careful monitoring and continuation of the planned PCI procedure. And so we have to take a decision to complete versus immediately terminate a planned procedure in the setting of a complication. And there are some basic principles. When a significant complication is suspected, we should have to act immediately or pause to evaluate. So there are 2 theories. There is a 60-second rule. First, take a pause and to assess the patients, consider the differential diagram, formulate a plan, and if there is a hemodynamic collapse, then try to stabilize fast. Then ask for help, and double scabbed operators should have a contact number and call the expert operators who have the same type of problems previously. The commonest, we all know that in case of primary PCI, we always face this type of problem, this no flow, low flow. There is an algorithm, and we should have these drugs in our cart, in our bags. Adenosine, verapamil, and eptifibatide should be in our cart. And this is a case of inferior MI. Look, the distal flow, there is no flow, and after the proper management, no flow is established just after using the drugs. And dissections, in the stent era, the dissections are less common, but it is commonly encountered in the CT operators, especially the Kaiser-wise like persons who do that CT frequently. They do it voluntarily. So this is an algorithm for the dissection management. There is a we should access according to the where is in the position or no. And the most important is this. Look, this is a perforation from the left main and to its progresses towards the LAD mid to distal part. And then the most important part is that we have to stent at the distal portion of the dissection first, and then we have to progress to the forward. And ultimately we finally, this is the final. And perforation like that, there's main vessel perforation, there's distal vessel perforation, and this is the perforation, grade 3 perforation after stenting and post dilatation, and balloon tamponade done. And this is the final view after second stent implantation, covered stent. This is not a covered stent. We sealed it by, fortunately, we sealed it by a second stent. And entry equipment already shown by Jafinapa. We have the wire stands. There are different techniques. We have to snare. There's a very well algorithm for the wires. This is the dislodged stent, and we retrieved it. And after the complications, PC operators may feel guilt and self-doubt in the aftermath of the complications, or if they feel like me, may reflexively blame others. Oh, the fault is others. So these negative impulses should not be done, and we should be transparent and judgmental, non-judgmental process to examine and learn from population. The goal should be quality improvement, not finding a guilt of others. We should disclose it to the patient and family and for their satisfaction, and we should be closely involved with the post-procedure management. So the take-home message is the complication management requires the preparation. We should adequate instrument, adequate equipments with us, early recognition and broad differential diagnosis, knowledge of effective techniques, team-based communication strategies, multidisciplinary collaboration, and algorithmic approach like that to complications will improve procedural outcomes and provide confidence for operators who plan to perform complex PCI. And that's all. Thank you. Thank you very much.